It's a huge problem in terms of the severity of disease, in terms of the number of people it affects, and in terms of its cost to society and days lost from work, etc. I try with this talk to give you an insight into physiology, to current concepts of pathogenesis and current management. Now, some of this will be repetition of what Gavin's shown already today, but it doesn't do any harm. And it will just reinforce some of the points. So your sinuses develop principally from in utero to about 20 years, although your maxillary sinus can carry on expanding depending on the number of teeth that you have lost. As you lose molars, your sinus will expand. So it's basically complete by 20 years, apart from tooth loss in the maxilla. So if you look, there's 3 phases of development: 0 to 3, 6 to 12, and 12 years onwards. So by the age of 12, your sinuses should be at the same level as the floor of the nasal cavity. And then they expand laterally into the zygoma and inferiorly below the level of the nasal floor. And your sinuses may be extensively pneumatized going between the tooth roots, as we've seen previously. An important structure in the central skull base is the sphenooccipital synchondrosis, which allows your skull base and indeed your face to grow. And that fuses earlier in females around the age of 11 to 12, boys 13, 12, 13, 14. And we can see at the age of 9, we have virtually no frontal sinus development. So your frontal sinuses predominantly develop in the second decade. Just have a frontal recess. So underdevelopment may be aplasia, absence of, hypoplasia, small, maybe unilateral, bilateral, or pansinus. And it's associated with several anomalies, including craniofacial syndromes, cystic fibrosis, and chronic rhinosinusitis in childhood will give you small sinuses. So unilateral 7%, I won't go through the science because Gav discussed them already. 2% bilateral. Increased height, the alveolar process, as we said, is the sine qua non of this condition. Narrowing fundibulum, often opaque from birth, and often asymptomatic. And there's gross or total aplasia of the maxillary sinuses. The other entity which can occur is hypoplasia in the sphenoid sinus, and this peculiar entity of arrested sphenoid sinus pneumatization, which gives you an island of fatty marrow indenting a sinus, or just fatty marrow and coarse trabeculae in the clivus adjacent to a sinus, which is usually small but not always. You've got to look on soft tissue windows. If you can see fat, that's what it is, and you don't have to do an MR, because an MR will just confuse you. So here it is, bilateral. Little bits of fat on the soft tissue window images. Looks a bit like fibrous dysplasia, looks a bit like a chondroid lesion, but it's not. Cystic fibrosis, you tend to get small, chronically diseased sinuses. And then the other feature of cystic fibrosis is that they have well pneumatized and clear temporal bones, which is a mystery to many. Physiology, we have cilia, which propel a mucus blanket, which acts like flypaper to catch inhaled pathogens or irritants. And that has to go through a patent sinus ostium to clear the sinus. We have drainage channels, the anterior being the frontal recess and osteomeatal unit, the posterior being the sphenoethmoidal recess. And there is a current concept of the unified airway, implying that the respiratory tract, upper and lower, is a uniform single organ, and that the respiratory epithelium has a common immune system. So there's interlinked disease between upper and lower respiratory tract pathology. So for example, if you have allergic rhinitis, you're more likely to have sinusitis, and you're more likely to have asthma, and vice versa. And outside this main triad, you can have problems with your middle ear, except that's not true, because there's no relationship between temporal bone disease and sinusitis, despite what it says in every ENT textbook. Laryngitis, for sure, and dentofacial anomalies and gastroesophageal reflux. I mean, this is flying saucer stuff again, I think. But you know, the main ones are certainly well described as associating. So, for example, if you treat somebody's allergic rhinitis, their asthma will get better. And it isn't because they're inhaling infected snot or something like that. It is a common immune reaction, and vice versa. So if you've got an exacerbation of asthma, you'll have allergic rhinitis, etc. So you inspire a particle, it's cleared in 10 minutes, the cilia beat very quickly, and the goblet cells produce mucus. So there's your goblet cell with the, producing the mucus. The dark glands are the serous glands, producing the watery secretions. So when you look at it schematically, you have the mucus on the top, which is like flypaper. It's thick and sticky. Then underneath that, you have the sol, or serous layer. The cilia beat in the sol, propelling the particles in the gel up towards the sinus ostium. So all those cilia beat up to the natural sinus ostium, and that's why antrostomies never worked, because they don't beat there. Okay? It's irrelevant if you put a hole down here, the cilia will still beat it up there. Normal thickness of the mucosa, you know, 1 to 2 millimeters. You can see it, it's not necessarily abnormal. So the frontal sinus, the cilia, they've done studies with dye and molecules and shown that the cilia actually beat the frontal sinus. They go up the medial wall, around the top, and down again into the frontal recess. The sphenoid moidal recesses, to see the sphenoid sinuses, as I'll emphasise, you have to look in sagittal and axial images. The coronals are of limited value. So your sphenoid moidal recesses, they're your drainage points. You see very well on axial and occasionally on sagittal images. So disease. So sinusitis equals rhinosinusitis, inflammation of the nose and sinuses. It's a clinical diagnosis based on 2 or more symptoms. Nasal blockage, nasal discharge, with or without facial pressure and decreased sensation of smell. So rhinitis usually precedes and leads to sinusitis. And you can see our involvement of our nose, frontal, ethmoid and maxillary. But the exception being dental causes of sinusitis, when the nose doesn't have to be involved. It's an absolutely thrilling 60-page article, which so it classifies, and it comes out every 5 years, and reclassifies sinusitis. I mean, it's the gold standard in discussion of sinus disease. And they classify acute rhinosinusitis as acute viral rhinosinusitis, acute post-viral rhinosinusitis, and acute bacterial rhinosinusitis. And then we come on to the chronic rhinosinusitis, and then the miscellaneous group, the ragbags, that most of which Gav's already shown. We've shown all of them, in fact. So acute sinusitis has a prevalence of 6 to 15%. Basically, it's the common cold. It's duration of symptoms for less than 10 days. Acute post-viral rhinosinusitis, it gets worse after 5 days, or the symptoms persist for longer than 10 days, but less than 3 months. Acute bacterial rhinosinusitis is suggested by 3 or more symptoms: purulent nasal discharge, facial pain, toothache, focal sinus tenderness, and fever. So all things you'd expect from a bacterial infection. So acute post-viral rhinosinusitis, we only tend to image when there's suspected complications. So we talked about this morning: opacity, fluid levels, and another tip, pneumatized secretions. That is said to be more commonly indicative of mucopus rather than just fluid due to rhinitis or something like that. We've also got bilateral obstructed osteomeatal units. So the pathogenesis is said to be, you get a viral infection, you get mucosal edema, and that knocks the cilia off. You get osteal occlusion due to mucosal edema, the sinus secretions become trapped, and you get bacterial infection. So acute bacterial sinusitis is normally a single sinus, and if it's maxillary, you have to exclude a dental cause, as we've said. So we see the fluid level, we see the mucosal thickening, obstructed OMU, we do our SAGIs, and we check for dental sepsis. There's none. Okay, as in contradistinction to this case, where we have periapical and periodontal sepsis around the root field 1-7. Sorry, 2-7 and 2-8. Sphenoid sinus, single sinus again. Okay, pneumatized secretions, another one, single sinus, drainage channels occluded. Axial is the best image for sphenoids. So chronic rhinosinusitis forms the bulk of what we do in terms of CT of the sinuses in this country. The major symptoms, so it's greater than 12 weeks. So it's a clinical diagnosis of facial pain or pressure, nasal obstruction, congestion, rhinorrhea, and postnasal drip. Epidemiology and cost is said to affect up to 15% of the population at any one time. And it costs in the US 22 million a year. Sorry, 22 million consultations and a cost of 3.5 billion US dollars per year. If the clinician looks in and sees pus in the nose, mucosal edema, polyps, or if we see mucosal disease on imaging, they're supportive evidence of CRS. But we don't make that diagnosis. We can't say it's chronic rhinosinusitis based on the CT. We can suggest it, but you can't definitively make the diagnosis. So how does it happen? Well, it's multifactorial. You get an irritant, you get an abnormal host response, maybe systemic or local. You get inflammation, mucosal thickening, and as we discussed, impaired mucociliary clearance, sinus obstruction. And that leads to CRS with polyps or without polyps. There's increased risk with increasing age, being a female, or having asthma or COPD. The irritants are just what you would expect, basically. Infection, allergens, chemicals, dental sepsis treatment. And dental sepsis and treatment are both underdiagnosed causes. The systemic factors, allergy, the unified airway theory, mucociliary clearance, so cystic fibrosis or ciliary dyskinesia. Aspirin sensitivity is very important. It's not something we know much about, but will lead to certain types of CRS, and the local factors. So all those things that are emphasised, like your Haller cells, your agar cells, and do they impair drainage? Well, no, they don't. Well, they do, and they're certainly important from a surgical planning point of view, but the only one that's ever been shown to have an increased incidence of chronic rhinosinusitis is septal deviation. We can see that tumours and fungal walls could impair drainage. So biofilm, the plaque, well, you get biofilms in your sinoid nasal region as well, just the same. You build up these microbial towers, fluid-filled channels. It's just like a little colony. It's lovely. A glue. And they're different. They're really hardy. They're 100,000 times resistant to antibiotics, particularly after they've had about 4 or 5 courses. And they consist of nasty things like Staph aureus and Pseudomonas. So there are immunological differences between people with polyps and without polyps, but they're not worth going into because the management is basically the same anyway. At the moment, it may be different in the future, and it also varies. There's interracial differences as well in the immune balance of people with and without polyps. But basically, with polyps, it's your IgE, eosinophilia edema group. And you may have sinus polyps as well when you don't have nasal polyps, so it's a bit academic. So we tend to classify it into anterior and posterior groups. So anterior frontal recess or osteomeatus unit, and posterior the sphenoethmoidal recess, and then all groups, with polyps or without. And that should really form the basis of how you give a conclusion of the pattern of disease. Or the entity of acute rhinosinusitis superimposed on chronic rhinosinusitis, which is more of a clinical diagnosis but can be supported by seeing fluid levels and pneumatized secretions. Then the rag bag of things. So the unilateral frontal recess pattern, the frontal recess being the drainage channel of the frontal sinus. You can see it's narrowed by ethmoid air cell variants. I'm not going to go into these. It's not this lecture. Bilateral osteomeatus unit pattern. Okay, you have covered this. And note that Haller cells, when they're small in particular, are best seen in the axial plane, not the coronal plane. See them here, and that's it there. It's quite indistinct on the coronals. Bilateral osteomeatal unit pattern with nasal polyps. Look on the axials again for polyps as well as the coronals, sagittals. I tend to look with MIPS and they help. And we've got 2 cases of sinusitis occurring in the posterior sinus groups. Case A, the left sphenoid sinus. Case B, the right sphenoid sinus. Now, axials, I said, were very good for posterior disease. Okay, you can see a patent right sphenoethmoidal recess, an occluded one in case A on the left, and on the right sphenoethmoidal recess is occluded. We look on soft tissue windows. We can see that in case A, it's low to intermediate density, but no suggestion of fungus. On the right, we can see the calcification and hyperdensity of an Aspergilloma in case B. So you always review on soft tissue windows. Facial pain, we showed this case today in the facial pain talk, where we have sphenoid sinusitis and the V2 neuritis. So if you've got facial pain and you see sphenoid sinusitis, you must flag it and say it is a potential cause of facial pain. And the mechanism is V2 neuritis, thought to be Ovidian neuritis. Pansinusitis, and again this would, you would say pansinusitis with or without nasal polyps, with polyps, without nasal polyps, but very bulky turbinates, so those turbinates are inflamed, that's rhinitis. Different immune mechanisms. And the reason I made that comment about the association, you see, I could never understand this. I'd looked at these things for years and looked at thousands of them, and I thought, hang on, you know, if this unified airway theory is correct, if you have sinusitis, why don't you have otomastoiditis? And I reviewed 200 cases. I've never written it up, I probably should, but what I found was that there was absolutely no association with sinusitis and otomastoiditis, and in fact people with chronic rhinosinusitis were more like cystic fibrosis patients in that they had clear and well pneumatized temporal bones. The only time their sinuses become diseased is when their adenoids become enlarged, which I don't understand. Another one. So the imaging features of CRS, mucosal thickening, polyps, retention cysts, fluid, protein content, various hyperdensity, contraction or expansion. And it's interesting, the maxillary sinus is the one, as Gav said today, that will contract and become thick-walled. The sphenoids do as well, but the ethmoid, the frontoethmoid region, tends to demineralize and expand. Previous surgery and mucosal calcification. So just a little potpourri. Demineralization and expansion of the frontoethmoidal region. Contraction and sclerosis of the left maxillary sinus. Mucosal calcification. And fluid of varying density and contents of varying density within the sinus, you know, which may or may not be fungal, they may just be hyperdense secretions. So sclerosing osteitis, we said it occurred in the maxillary and the sphenoid, and it's actually been classified, and this is the same patient in the space of 5 years, and you can see the change in the osteitis of their sphenoid sinus walls in response to chronic disease. And a surgeon classified this as mild when the sclerosis was less than 3, moderate 3 to 5, severe greater than 5. The important thing is that it's not just a response to mucosal inflammation, it actually works in reverse to exacerbate the mucosal inflammation so that it becomes a vicious cycle. So if you see a sphenoid sinus which has been treated, it may well have sclerotic walls and at some stage has been diseased. So acute on chronic rhinosinusitis, how do we diagnose that? Well, it's kind of a difficult diagnosis. If you've got a previous study which shows that they've got it, or there's a long history, We can see the obstructive frontal recess and osteomeating unit. We can see the fluid level. And if we have a unilateral opaque sinus, we'll give contrast. I probably wouldn't have given contrast for this case, but you want to exclude your inverting papilloma, as Gavin said, and you can see there's no obstructing mass. There's a fluid level inside the mucosal thickening, and there's a low density of polypoidal opacity in the nasal cavity. So that's just an inflammatory polyp. Okay, the miscellaneous, the rag bags, we'll go through these pretty quickly because we've been through them already. Allergic rhinitis is not a radiological diagnosis, but it may be supported by bulky turbinates and nasal polyps, as shown on this anterior rhinoscopy view of an inflammatory polyp. So allergic rhinitis, you may suggest it with bulky turbinates, nodular mucosa and polyps, nasal polyps. And I review them in multiple planes, not just the coronal plane. It's amazing how often you do a SAG and you can see more polyps than you could before. Retention cysts, obstruction of a single gland, they're dependent, they're water, but they may actually be proteinaceous as well, usually of no relevance. Antracranial polyps. Mucoceles. Now we said they're expansion of a single sinus resulting from sinus obstruction and inflammation. Commonest region being the frontoethmoid followed by the sphenoid. And here we see on post-contrast CT an infected frontoethmoidal mucocele with a thick enhancing wall and displacing the globe and causing proptosis. Another one with proteinaceous fluid. Look at the compression of the orbital contents in the globe. Fungal balls, mycetomas. Contracted thick walled sinus. Remember, maxillary and sphenoid contract and thick walls. The signal void. Another one. Fungal ball. Facial pain and referred otalgia, the causes of both of those. So, it's something to suggest if you're doing a CT. Then the entity of allergic fungal sinusitis, which is the step up from the Aspergilloma, where you get an allergic response to the presence of fungal hyphae with a proliferative mucosal response. It's expansile, it can look quite aggressive, polypoidal, it's high density on soft tissue CT, and you lose T2 signal just like you do with Aspergillomas. Maybe unilateral or bilateral. Unilateral can be a bit confusing, but look for the hyperdensity. And then the silent sinus syndrome. The sucked-in walls, lateralized infundibulum. But the difference is that the height of the alveolar process is normal as compared with the hypoplastic sinus, where the height of the alveolar process is increased on the affected side. Odontogenic causes, tooth roots poking into the sinuses. Periapical sepsis, unilateral opaque sinus, always exclude a dental cause. Don't think, because your osteomeating unit is occluded, that it's a non-dental cause. Although we characteristically think of anterior ethmoid disease being the key, leading to secondary frontal and maxillary sinuses, it may occur in reverse. You may have an irritant here, which causes the mucosa to swell, become inflamed, blocks the OMU, which subsequently blocks the ethmoid and frontal. So it can go in reverse. It's not well described, but it definitely does. Periodontitis, we said, is bad news, both for your general health and the state of your dentition and mucosal thickening in your sinuses. So inferior mucosal thickening, think dental as well, symmetric, periodontal rather than periapical. When you report it, grade it as bilateral. Look at the symmetry. This is bilateral symmetric mucosal thickening, mild, mild to moderate, severe, polypoidal, severe polypoidal, with hyperdensity, it's allergic fungal sinusitis. Unilateral allergic fungal sinusitis, you can see the hyperdensity even though you're not on soft tissue windows. And then previous surgery. Most surgery is done endoscopically. We grade the disease as moderate on the right, There's been there's occlusion of the right frontal recess, and there's been previous endoscopic surgery on the right. So the reason being why that frontal sinus is still diseased is that the surgeon has not managed to remove these anatomical variant air cells, which are very difficult to get at with a scope. So the aims of treatment are to reduce inflammation, control infection, restore the mucociliary drainage, medical, steroids, antibiotics where indicated, and other. Surgery, almost completely endoscopic sinus surgery these days. You can do balloon sinuplasties where you actually pass an angio-type balloon up on a guide wire into the sinus and dilate up the drainage channel. And then inframeatal antrostomies and cold wire look procedures have been by and large confined to the history books. So where might it obstruct? Well, might obstruct in the frontal recess and anterethmoid region, might obstruct in the osteomeatal unit. So you deal with that by doing an anterethmoidectomy and removing the uncinate process to re-establish drainage. Here is the same procedure being done endoscopically in schematic form, and that's what successful FES can look like. We've done an unstectomy and an anterethmoidectomy. Problem is the scopes. They're 30 or 45 degrees. They can't get around the corner. So some of these superiorly extending air cells are just physically impossible to get with the scope. So that's why you may have residual frontal recess disease. So the outcomes, the Cochrane review is the gold standard of assessing anything. It's safe, but according to them, it didn't have a lot of benefit over medical treatment. But it has been proven to result in fatigue scores. People definitely feel better afterwards, but it's not something that could be measured as an outcome in the Cochrane score. As we said, it's not just an increased risk of mucoceles with cold word looks, there is an increased risk with FES as well. So increased incidence of site trauma is previous FES, septoplasty and turbinectomies. Okay, huge sphenoid sinus mucocele. T1, proteinaceous. The T2 imaging, deficient dehiscence of the podium sphenoidale and the margins of the pituitary fossa. Okay, the alternative, well, nasal irrigation. You know, you get some great things on the net, don't you? Manuka honey, it's got to be Manuka apparently. It's got to be Kiwi Manuka honey from somebody's field opposite the mountain. And you make it to, it's actually been written up and does work. It's been written up by somebody in Auckland. They've done a study on it. They melt it, put it in hot water, let it cool down. And they use it as an irrigation. It's a natural, it apparently decreases the inflammatory response. The other thing that's been written up is Johnson's baby shampoo, diluting water to get rid of the biofilms. You're trying to break those biofilms down. And then you can buy this thing that looks like a Japanese teapot and pour it down one nostril, swill it round at the back, and then let it pour out the other one. Yes. So in conclusion, CRS is a chronic inflammatory disease of multifactorial etiology. It's common and leads to significant morbidity and economic cost. And CT plays an essential role in planning and evaluating treatment. Reports should be clinically relevant. Thanks very much.